time, Mark, I don't want to disrespect you, man, but I really don't think that any introduction I'm going to do is going to give you justice. So I'm going to say that you've been doing this for a couple weeks.
Yeah.
You're one of the names for a reason.
I stayed at a Holiday Inn Express last week, and I play one on TV.
I'm looking forward to this, man. I already know what your slides look like, and I'm still looking forward to, popping some popcorn and hanging out. So without further ado, I'm gonna give it to you, man.
Okay. I think most of you know me. If you don't know me, this all comes with a giant asterisk up in the corner because I am the chief dental officer, lead clinical faculty, whatever you want to call it, at ProSomnus Sleep Technologies. And so you've got my email there. I teach at the Detroit Mercy Dental School. I run the sleep program down there. I practice 1 day a week in Rochester Hills, Michigan. But mostly I do a lot of lecturing, teaching, clinical trials, product testing, development, things like that for ProSomnus. And I answer, we have probably about 60 new customers a month, maybe 65 or 70, I guess, some months. And I work with a lot of new doctors coming on board. I work with companies like Awaken to Sleep. They've been an incredible partner for us in helping doctors that want to do more sleep, grow their practices, and implement dental sleep medicine with their teams. And so they've been a great partner, because without them, I don't know how some of these practices would be more as successful as they are. So that's kind of my life. Tonight, we're going to talk about oral appliance therapy from the perspective of dose management. And I think that term should feel a little weird to you. I don't think a lot of people talk about dose when they talk about oral appliance therapy, but that's how I want you to think about this mandibular advancement. Dose is how I want you to think about that, because when we think about oral appliance therapy, we should be thinking about pretty much any therapy, any treatment, any medicament, anything that we give a patient in the medical world to help them get better. And the idea is there's a therapeutic window. There's a range at which the therapeutic effect of the medication, the drug, the treatment, the therapy works without causing problems, toxic side effects, toxic effects. And the worrisome thing would be is if you need more and more blood pressure medication to bring your blood pressure down, and it's not working, so you're taking more, and you're increasing the dose, you're taking more, sometimes the side effects are so significant that it causes you to discontinue treatment. So I want us to think of this therapeutic index, therapeutic dose. Excessive dose causes increased side effects, more challenges, and things that we can do in dental sleep medicine to manage and minimize the dose are going to help us be more effective in our therapy, driving better outcomes at a lower dose. And certainly there are things like I tell my patients that some patients get dry mouth and some patients get pools of saliva next to them on their pillow. That's a pretty subtle toxic side effect of an oral appliance therapy. And there are some things like muscles feel a little sore because we're advancing kind of far. We're halfway into the range of motion. They've got a small range of motion. So for that patient, maybe we have to try every other night or back them up and start more conservatively. So there's things that we can do that are interventions to mitigate or manage those side effects that are just nuisances, but we can overcome them. And then occasionally, rarely, fortunately for me, I've been very successful with not having many patients discontinue treatment because the side effects were so bothersome. But I can think of one particular patient they just could not accommodate their jaw muscles, how they felt coming forward. And they were just uncomfortable. And it was really difficult for me to look the patient in the eye and say, I am so sorry, but you're going to have to go back on CPAP. Now, I'm not uncomfortable saying that when the therapy doesn't work, because if we're doing pretty well at about 3 out of 4 patients, including severes in the whole mix, higher than that for milds and moderates, but 3 out of 4 patients we're treating successfully, a little higher than that maybe with EVO, with oral appliance therapy. But I'm comfortable. I'm used to saying to somebody, your AHI score didn't come down enough, whatever the metrics are we're looking for, time under 90, that just hasn't improved enough. You need to go back on CPAP, because we can't treat everybody, because we know that some people have really low arousal thresholds, some people have really high loop gain, some people have weak pharyngeal dilator muscles, and we know that some people have just a mechanical inability to advance their mandible enough. I can't pull the cash register far enough forward, if you will, to open their airway. I'm okay with that. But man, the side effects one just bugs me, because I try to use a platform with these precision devices, these ProSomnus precision devices, that has less side effects. So here's the thought I want you to have. If I were, and I am, a dentist, and I were designing oral appliances, I might get stuck in this paradigm. Because what we saw for the last 30 years. I made my first device 35 years ago, teaching with Keith Thornton down at Pankey, is cobbling together using acrylics, cold cure and bench cured acrylics, different mechanical parts and pieces that we stole from orthodontics. And in doing so, we made great devices for the time. And we cobbled those things together, and we had jack screws, and we had Herbst arms, and we had straps, and we had large handles that would, I remember my first tap I made had a large handle coming down from the upper device that hit on this flat platform in the front. You had to advance the mandible far enough for this thing to drop in. And we weren't doing a lot of good testing. We weren't doing a lot of communication. But we stayed inside this dental paradigm, and we kept coming up with solutions that were like faster horses. We were trying to use dental parts and pieces better. I was involved back in the microdental days with the development of the oral appliance therapy devices, platforms that we have now at Persomnus, when it was inside microdental back in 2013 and 2014. And I remember having the engineers come in that we had hired from 3M to work on the devices. And they didn't say, well, what do you want us to make? They said, tell me what you want these devices to do. They asked us for inputs regarding treatment outcomes, performance outcomes of the materials and the devices. They didn't ask us what we liked or didn't like about Herbst arms or jack screws or anything like that. So they came in with a very fresh paradigm, and they said, here's a new and innovative device. And here's this milled platform with precision, this milled platform that was going to be smaller and easier to keep clean. And we said we didn't want to have to advance the mandible as far. And so they gave us more tongue space, lingualist design. And we wanted it to hold its position, so they gave us 90-degree posts. Wanted it to be easier to keep clean. So you get the idea. They took an engineering perspective and took our design idea inputs and came back with something that was not cobbled together from parts and pieces from dentistry. So that was innovative. So that was cool. And then the second thought that we have to have when we're thinking about this is, what are the goals we're trying to achieve? And Steve Covey said it so well in his book, begin with the end in mind. So if we also say, what are we trying to achieve? Then we start to design devices that are trying to achieve our goals. And the first couple of goals we think of are pretty obvious. We want to get the AHI down. We want to, reduce the subjective signs and symptoms. It's not enough to just get the AHI down. Patients want to stop snoring. They want to feel better. They want to sleep better. They want to have better rest. We also want a device that is easier for them to wear. We want a device that minimizes side effects, so we don't have to advance them farther. They're not bulky devices that take up tongue space. So you can see the clinical design characteristics that we want to have when we think about this end in mind. And so we could say the end game, the goals, the objectives are, we want to apply a minimal therapeutic dose. Let's use language that they use in medicine. We want to have exquisite, great compliance or adherence. And we're going to achieve that by having better device selection. We're going to be able to minimize or remove, reduce, eliminate, mitigate our side effects by doing that and have great outcomes. Oh, by the way, who do we want to design these for? Well, I want to design these for patients so that the patient has a better experience. I want to design these devices for providers, for you and I, so that we have a better experience. I want it to deliver easy. I don't want to have a lot of breakage, adjustments, repairs, side effects, for sure. But what about physicians? We took the time to survey a lot of physicians and find out exactly what they wanted and what they didn't want, and what they knew and what they didn't know about oral appliance therapy, so that we could answer some of the questions that they weren't asking, but that we asked them, so that we could design devices that fit protocols, procedures, outcome desires, inputs, if you will, from them. And then what about payers? We want devices that do have a significant impact on outcomes, because we've all seen things like the McAvoy study, the SAVE trial, which didn't demonstrate a difference in cardiovascular risk of death in a treated versus an untreated CPAP population, or the entire AHRQ paper, which talks about maybe CPAP isn't an effective treatment for OSA because it doesn't impact the outcomes enough. So these became the kinds of things that led to better design inputs, because historically, PAP therapy hasn't worked well. Physicians would argue oral appliance therapy, legacy devices, large bulky designs, big metal parts have been a challenge. And think of them as not the newer, modern, smaller devices. They're being designed with great innovation, smaller size, design, less bulk, less volume. That's great. And then even some of the things that have come up that sound really cool, like Inspire, no mask, no hose, just sleep. But they forget to tell you it involves surgery where you get a pacemaker-like device implanted in your chest and some wires running up your neck to the base of your tongue to do nerve stimulation up there. And they forget to tell you that the efficacy is around 66%. 66%. And the target was getting those patients in the STAR trial below 20. And the adherence is about 76%. And the side effect ratio is about 35%. So it's not like Inspire, $50,000, $40,000 maybe, is an outstanding, easy, and very effective treatment. No, just the contrary. It's a very expensive, not very effective treatment. So see, this whole methodology of trying to find a way to communicate to physicians, to speak to physicians, to listen to physicians about what we can do better, because they control $4 to $5 billion a year in OSA treatment prescriptions. And dentistry with oral appliance therapies gets 5 to 7% of those. If we can shift their focus by lowering the dose, improving the side effects, the outcomes, the efficacy with better devices, better device design, and we just change their prescribing patterns by 10%, it would quadruple the market of what we have for oral appliance therapy. So what we found is that if we listen to physicians, if we listen to our customers, if we listen to patients, even if we listen to insurance companies and payers, we can learn a lot about how we can design devices to meet and exceed the goals and expectations that they have, not just that we have. If we stay within a dental-only paradigm, we sometimes can get very stuck in making faster horses instead of better cars. And that's been a challenge for us, I think, in dental sleep medicine for some time. When we surveyed physicians, here's what we found. They had 3 different characteristics or categories, if you will, of things that bothered them. And they told us that they would increase, you can see this data, by 4.6x the number of oral appliance prescriptions if we could overcome these barriers: device barriers, provider barriers, and logistical barriers. And what they understand is we don't have a clearance from the FDA for any device to be used to treat severe obstructive sleep apnea, just mild and moderate. Well, there's a recent paper that I'll share with you a little bit later that was in the Journal of Clinical Sleep Medicine this month. I'm sorry, it was in March, published in March, that showed 81% efficacy, including mild, moderate, and severe, 94% efficacy for mild and moderates using precision PreSomnus platforms. It's the Remmers and Mosca study. It's incredible, incredible data. And so we're working on a FDA clearance for EVO, for severe obstructive sleep apnea. And that will help bridge that chasm between what physicians believe and don't believe about what oral appliances are capable of doing. We know that we can win with adherence because patients have a much easier time wearing that, but it's hard to prove that. We're starting to, you see more requests. I had one today. I was just talking to Mike before we went on the air, a patient that is an airline pilot who wants a compliance chip in a device because he's got to be able to prove that he's wearing the oral appliance just like he would have been wearing the CPAP so he can still fly. Good results for efficacy for mild and moderate. We've talked about that. Reducing side effects. Insurance coverage. Most physicians, half physicians don't understand that it's covered by medical insurance. And there's still a lot of dental sleep medicine providers that don't enroll in Medicare. And most physicians are kind of looking for that kind of relationship to make it a little bit easier for their patients. And then they don't really know who they should send these patients to. And that's a challenge because who's a qualified, I hate when people do that, but who's a qualified provider? Who's qualified to do this? Just any Joe come lately or Mary come lately who took a weekend class? Well, I hope not. I hope they've done a little bit more training than that. And at least the AADSM has developed this set of credentialing that you can go through to become a qualified, and ultimately, if you want a diplomate or a board level training for dental sleep medicine. And then logistically, we don't know who's going to respond and who's not going to respond. We've talked about the compliance monitoring. We're going to see incredible developments in the next probably 12 to 18 months of chips and monitoring devices with physiologic parameters that will allow physicians to have real-time data on patients, not just wearing the device, but getting information about heart rate and other important metrics that they need to know that they're in treatment. And then a lot of times physicians would say, and they were right in the past, boy, it takes forever for these patients to get their devices. They willy wonk around for a while, and then they finally get in and they get their testing done. Then they got to go get their impressions, and 3 or 4 or 5 or 6 weeks later, they get their device. And so it's 2 or 3 months. Well, now it's 6 months to a year to get a CPAP machine. So suddenly this little time delay, we look pretty good. So if we can overcome some of these barriers by designing better devices, by having a lower dose, we can be more effective.
Hey,
So,
Mark,
yeah,
I want to hop in a couple of questions
go
that have
for
been
it. Yeah.
coming in, man. Because you were dropping some bombs there, and I want to make sure we hit on that. But yeah, I'll also give you a chance to take a breath. So first thing, you specifically said the mild and moderate efficacy, the severe efficacy from the newer study, but from an FDA clearance, it's mild to moderate or CPAP failures. As a long,
No, from the FDA clearance standpoint, it's only mild and moderate. From an ADSM, AASM joint guidelines, it's mild, moderate, and CPAP failures.
Got it. So from the physician communication standpoint, you've been doing this with MDs in your backyard for a long time.
Yep.
Is there any benefit to communicating with them on the combo therapy level where you're saying, hey, I'm going to help increase your CPAP adherence by using combination therapy? Or is it strictly just they failed CPAP and they're coming for an appliance? How does that work out with you? That summarizing the question.
Yeah. So combination therapy is great. And there's lots of different combination therapies, whether it's positional with an oral appliance, whether it's CPAP and oral appliance, there's lots of weight loss in oral appliance, there's lots of different things, nasal treatment in oral appliance. That's a very small percentage. Is it important to be able to have that conversation? Absolutely, because I think that brings the two of you together, the physician and the dentist together in a conversation, rather than being opposed. And so that's a good thing. But it's a very small percentage of patients that ever end up in that kind of combination therapy. But it does allow you to lower the pressure usually by about 50%. Yep. And if the compliance has anything to do with the mask wearing, lowering that pressure makes it a lot easier. So sometimes with certain physicians who are just CPAP blinders, that's a great way to bridge that chasm with that particular physician. Once you get in and do a few cases successfully with them, they see you get the patients below 10. They're like, holy crap, this stuff's for real.
Yeah.
Then they start to believe.
Yeah, it makes a lot of sense. And I will say, from my background coming from the sleep medicine world, I worked at a med device startup company, consulting for them years ago. And the number one patient intolerance issue for CPAP wasn't the mask, it was the air pressure. So the fact that oral appliance has a direct impact on that, you're actually addressing the number one issue with compliance for patients. So yeah, it's on point, man. One other thing I just want to highlight, and then I'll get out of the way. You said something that was super important. You said minimal therapeutic dose for maximum medical improvement. And if I can just speak to the audience right now, if you didn't write that down.
You actually said it better than I did, because I just said minimal therapeutic dose. You added the second half of the absolute truth statement for maximum therapeutic effectiveness. I love that.
Yeah. Make sure you guys write that down. Well, and Dr. Booher, I see your question. Yes, we will have a recording that's available for everybody to watch. That's posted on the website by tomorrow, I believe. So yeah, Mark, doing a fantastic job, man. I'll get out of your way. Keep plugging away.
You are not in my way. You are welcome in my kitchen anytime. So a lot of the device barrier issues are solved if we start to use precision devices that have lower doses. Certainly there's some educational things we have to do a better job of teaching physicians about and teaching maybe even payers about. And then certainly technology is going to help us solve some of those logistical barriers. There isn't any reason, at Prosomnus, we turn them around in 7 production days, and we're meeting that 98% of the time. We're on time 99 or 98 or 99.5% of the time. It's ridiculous now. But Still, technology can shorten that time frame because the idea of impressions, scans get sent right to California. 80% of our stuff comes in digitally. So turning that stuff around faster and faster and helping to close that time gap will always still be important, and technology is going to help with that quite a bit. So we're talking about dose and we're talking about better efficacy. So what do we mean by better efficacy? Well, we're seeing some incredible results lately. On the far right-hand side is a poster from World Sleep. We've got a couple of posters of World Sleep. One is on better efficacy using Evo, where it showed 84% efficacy in mild, moderate, and severe combined patients. Crazy numbers from 4 different centers. This is a poster on data that was pulled out of some of the NOTICE trials by Remmers, Mosca, and Suresh Sharkandi, who many of you might know. And it showed incredible results, again, for precision oral appliance therapy platforms. But the study in the middle is absolutely a mind blower for me. That is the Journal of Clinical Sleep Medicine. So it's not a dental journal, it's a peer-reviewed journal, and it's in the medical community. And it shows that in this study, using precision platforms, PreSomnus precision platforms, mild and moderates were treated effectively below 10, 94% of the time. And all severities, including patients over 30, 81% of the time. So we're starting to accumulate data that's demonstrating to the medical community that we have better devices with better therapy, with better results, better outcomes, better adherence, fewer side effects, lower dose, that are more effective treatments. The adherence component's important. We've done several studies with compliance sensors in them. Stern, physician Jordan Stern out of New York, did a great study called the EFFECT study, where he looked at the MDA, the mean disease alleviation, and the sleep adjusted residual AHI. In fact, I think we've probably got, on precision devices, we've probably got the only 2 subjective, objective compliance recording studies that Jerry Hu did and Jordan Stern did with compliance chips in there. Incredible compliance. We're not in the 40, 50% range, and we're not talking about 4.5 hours, 5 nights out of 7, but with this lower dose, less advancement, more comfort, it's easier to wear these devices, and we're getting the 90% kind of numbers, which are superior to anything we see other than maybe MMA. You know, when you see a mandibular maxillary advancement, that's going to be pretty compliant. It's hard to reverse that. But these are phenomenal kinds of data pieces and studies and articles that we can share with our physicians to help them understand what's going on. When we think about what we're able to do with mild and moderates, again, that's that study in JCSM that was just published. And if you email me, I'm happy to send a copy of that article to any of you. But 94% of those patients were treated effectively. We've looked at dosage postering. We've got outcomes dosage in oral appliance therapy device selection, Rose Rahaki out of San Diego. And then we've got Eddie Saul, a physician. He's an ENT up in Syracuse, New York. He did a study looking at 135 consecutive cases using PreSomnus precision platforms and showing about 76% efficacy, including mild, moderate, and severes, in about a roughly equal mix. And so what we've seen with oral appliance design evolution, and you can see that in the top graph in the middle, is a gradual improvement in the efficacy from below 50% if we go back to the 1990s to we're approaching 70% efficacy, especially if we start to look at the PreSomnus style platforms. Evo seems to be inching even past that a little bit. We're seeing some crazy numbers with that, but these are nutty numbers in terms of how much we've been able to improve oral appliance therapy with intentional precision design that's designed to reduce dose, improve outcomes, efficacy, reduce side effects. And most of that is just they're smaller, they're stronger, they're easier to keep clean. And we can have fewer efficacy leaks. I love that term. John Remmers talks about that. He talks about, there's some number and we don't know what it is. Is it 85%? Is it 90%? Whatever the number is of patients that could really be treated with oral appliance therapy. We don't know what that number is, but let's say it's 85%. We leak efficacy out of that bucket. We leak it with poor technique, poor bite registration, poor precision. all of those kinds of things start to accumulate with deficits of what we could do. Now, there's some patients who are going to be non-responders, high loop gain, low arousal threshold, weak pharyngeal muscles, mechanical disabilities that we can't override with advancement, with dose. We can't fix those people. But after that, anything else we leak because maybe the starting position was off, or maybe we have to advance the patient too far because the device is bulky and it increases side effects. All those kinds of things really make us look bad in the medical community because they give us data and numbers that aren't as positive and predictive. When we talk about fewer side effects, there's a lot of things that contribute to that, whether it's precision prescription transferring. At Prosomnus with the precision devices, they transfer the prescriptions using articulators for all the cases, either virtual or Stratus articulators. Every case is mounted on an articulator and not just fitted on printed models, all the cases that come in digitally, but they're actually put on articulators so that we know that we're giving them back the device at exactly within 1 millimeter, actually within less than half a millimeter of the prescribed position. And when we did a study, Jerry, who did this for us up in Alaska, looking at multiple devices made for the same patient at different manufacturers, we got devices that were several millimeters off in different dimensions. That's going to mean for a longer and harder titration, maybe asymmetrical titration, more discomfort. When we have devices that are harder to keep clean, patients are going to struggle with those. So having materials, I love the idea of printed materials. Prosomnus is not wedded to milling devices. We're wedded to making devices out of the best material that we can find with the best technology that's available from a CAD/CAM, artificial intelligence, robotic manufacturing standpoint. Today, we feel that's milling, either polymethyl methacrylate or the MG6 technology material that we use for EVO. But tomorrow, somebody might come to us and show us a new material that's printable. But today, the printable materials are very porous, very flexible. They invite a little bit too much more tooth movement, and they're really hard for patients to keep clean. And then the overall volume of the device is such a huge component to this whole precision idea, because if I'm pulling the mandible forward to bring the tongue forward and open the airway in the back, the moment I bulk up the lingual component with a large hook and ladder kind of configuration in the front, or paddles of acrylic that just take up a lot of space because they're hand cured, cold cured, or bench cured under a little bit of pressure and temperature. When we can mill that material, we can mill it so much smaller, so much thinner. We can make areas lingualis that we don't have to pull the mandible as far forward. And then when we have this precision fit that I'm talking about, that a device can have when it's milled and fits like a retainer, we don't get tooth movement. I'm in a conversation right now with Gene Santucci out of University of Pacific. He did the 2-year study for us that's shown on the upper left-hand side. It was published in JDSM, 2-year study of our acrylic platform showing no tooth movement. We're going to repeat that at a 4-year study now, showing no tooth movement, we believe, for the acrylic platform. And now that we've got enough cases out, thousands and thousands of cases of EVO, we'll do that at a 1-year interval, and we'll demonstrate no tooth movement. We kind of cheat. We've actually done some overlays of scans in Ortho Analyzer software. So we've got a handful of cases, not the dozens that we need to get a statistical significance, but we're very confident we'll have a positive outlook when we look at no tooth movement. So here's this family we're talking about precision platforms. And we've got the flagship product that you see all the time now, everybody talking about is EVO. It's got a little bit of flexibility to it, which is kind of cool. But EVO, IA, and the IA Select are all iterative advancement devices. The PH is a Herbst device with some platform advantages. The CALP is a dorsal style device with some platform advantages. But the IA, the IA Select, the PH, and the CALP are all acrylic devices. The EVO is the only device today that has got this little bit of flexibility to it, this special material. We've got this MG6 medical grade 6 technology material. We'd like to produce, and are working on different versions where we could maybe make some sort of a precision Herbst that would be made out of that EVO material, and ultimately some sort of a dorsal device or a jack screw device. But right now, this is the family of products that we have. And certainly we try to design as many innovations and advantages for the patients, but what we couldn't do with the Herbst device, because of the way the arm is aligned, is we couldn't create this 90-degree post configuration that we have on the other 3 iterative advancement devices, and the one dorsal device that we have, the continuous advancement, or the CALP. In those devices, this vertical orientation of the posts is a rather significant feature that I just want to kind of detail for you a little bit. The beauty of that is if I've got a 70-degree post, now remember our discussion earlier about if I'd asked them what they wanted, they would have said faster horses. If we'd have gone to dentists and said, what do you want? They'd have said, I want a better dorsal. And they might have said, and I want it to be at that same 70-degree angle that all the other dorsals are at. Why? Well, because that's how all the other dorsals were made. Well, why were they made that way? Well, they were made that way because 70 degrees is approximately the angle of the arc of the curvature of a 4-inch Munson sphere that the mandible rotates open and closed on. So it made sense. It really did make sense when you think about it. I'd want to design something that opened and closed in the normal functional movement of the mandible. It actually does seem very comfortable to me, because I'm a dentist, as a thought. But when we went to Sung Kim, the engineer from 3M who came over to Persomnus and helped us develop and design, he really invented this thing. He said, what do you want the device to do? And one of the inputs we gave him was, we said, Sung, we want the device to not just be at that position, but to keep the patient in that position and hold them stabilized in that position. He said, what do you mean? He said, well, if the patient's mouth drops open while they're sleeping at night, I want to still be able to maintain that therapeutic position. So he comes back with these 90-degree posts, and we said, why'd you make those posts 90 degrees? He said, that's what you asked for. And I remember saying to him, looking at these posts, and I said, we didn't ask for 90 degree posts. He goes, yes, you did. I go, tell me what I said. He said, you said you wanted to stabilize and hold the mandible in that position, even if the patient's mouth dropped open. I said, yeah, but I didn't say 90-degree posts. He says, well, if you made it 70 degrees and the patient's mandible dropped open 5 millimeters, you can see on this chart right there, they'd retrude 1.8 millimeters. That would mean for some patients, I might have to protrude them 1.8 millimeters more to keep them in a therapeutic position. As a dentist, I would have thought, I want to make sure that that device opened and closed on the normal patient. But an engineer said, you want to hold them in that position, so we'll make that post 90 degrees. The beauty of that too is I hardly ever have to use elastics because of that, because the pressure on that post is enough to hold that patient in that position. So
Yeah.
really cool and innovative kind of engineering design that we don't normally think of because we're dentists.
So a couple of questions from the audience. I'm going to summarize here, Mark.
Yeah, thank you.
We got the IA and the Evo that are, and the stuff from the folks that are making your appliances that are 90 degrees, and that makes sense. We've got plenty of folks on here that are going to have patients that walk in with a 70-degree angle fin, or they've, delivered those themselves, that kind of stuff. So bring it back to everybody else that's already done some of those angled fins. In that circumstance, what have you done in the past? Is there anything that you would modify the appliance, or you just titrate them further forward? Like, how do you handle that?
Yeah, in a patient whose mandible drops open, you would have to titrate them forward a little bit more. And you'd find that when you looked at where was the therapeutic position in relation to the percentage of range of motion, for patients with Herbst devices, patients with traditional dorsals at 70 degrees,
Right.
They're going to tend to be a little bit further forward. The first device I ever wore in 2012 was a pink dorsal. I'll just say it was pink colored from a company that part of their name sounds like part of our name. I don't want to mention anybody, Somnomed, but I wore a Somnomed, oral appliance when I first was diagnosed with sleep apnea. There was no oral appliance made by any company. There was no company called Persomnus. And so that was the first device I got made, and it worked fine. Okay. Worked great. But I probably was more advanced than I had to be if my mouth dropped open. Didn't know that, didn't understand that concept, because I was looking at that, and the post design, the angle design made perfect sense to me. Would I change that out if I had a patient and they were in therapy? Well, hell no, they'd be fine. There's nothing wrong with that, right?
Yeah.
And so when it comes time for that patient to get a new device 3 or 5 years later, now you have options. And here's what's kind of cool. With a smaller device with more tongue space, with a device that stabilizes the therapeutic position, that patient might need to be 1 or 2 millimeters less forward than they were in their other device to still be in a therapeutic position. That makes it easier for them to get their bite back in the morning, less likely that their bite changes, less likely that there's tooth movement, more comfortable on the temporomandibular joints and their muscles. I mean, everything you get on the list, it's cool.
Yeah.
So those are the advantages, but I would not go out and replace some device because I had a 70 degree. That's fine. God no. And I've done plenty of Herbst arms because patients, you know, when I couldn't do I do this little thing with a primary device and a backup device that they sign an ABN for, so I can deliver 2 devices for a Medicare patient. That's a good topic for another webinar. But when I've delivered Herbst devices, that's one of the things in the back of my mind. I'm thinking, oh crap, you know, that device, they just drop down wherever they want. Doesn't really hold them in that position very well at all. And so in that case, I'll often use that's why those devices come standard with elastic hooks. That's because we probably should be using elastic hooks on those devices to hold them closed because they're going to retrude.
Got it. Is there any other case, because elastics was another question, so I'll just kind of loop it in since you brought it up. Is there any other circumstances where you'd use elastics and order it as an add-on on any other case?
Yeah, so they come standard on all my Herbst devices, and I leave them on there unless the patient doesn't like the bumps. And I give the patient the elastics and I explain to them how they're used, what they're used for, and it's their choice. I can't say never because that would not be true, but I rarely order elastics on an IA Select or an Evo. Now I've had a couple of times where I wish I had, but it's like, if it's 1 out of 100, then I carve a little nook in there that an elastic will fit around, and the acrylic, that's easy to do. You can do it in the Evo as well. It's not a problem. Or I talk with all my patients about dry mouth and keeping their lips together and lip competency. And I tell them the surefire best way to do that is something that they'll think is kind of weird. And I talk about taping. I tape every night myself. I use 3M Medipore tape. It's fantastic. It promotes nasal breathing, nasal patency, and it prevents me from having a dry mouth. So I talk to a lot of my patients. I tell them if they have dry mouth, probably the best thing for them to consider is taping. They go, taping? I go, yeah. Do you ever see a tape face guy on America's Got Talent? They go, yeah. I go, well, special kind of tape, not duct tape.
Yeah.
But it works great. They're like, and I pull out a roll and I show them, and they think it's weird. My grandkids think it's weird, but it works fantastic.
But then they got to go home and tell their spouse that they were right, that they should just, tape their trap shut and it would fix their issues.
Amen.
Get back to it, man.
Problem solved. Problem solved. So at Prosomnus, I don't want you to think that it's just about using CAD/CAM. It's about using materials well. It's about using artificial intelligence that helps design these devices, and robotic manufacturing that's precise. When you see the kind of anatomical contour across the facial and the lingual of the IA Select and the Evo device, it's pretty cool looking, but that's not somebody carving those little fenestrations and indentations between the roots of the teeth remotely and arbitrarily. That's actually, the software extrudes the patient's own anatomy in exactly the proportion that they see for each tooth. I was actually on a call with John Rimmers today. I was on 2 calls with John Rimmers today. And on one of the calls, we were talking about that very thing, and Aaron Mosca. And I was saying that, we don't have an answer to why Evo, why IA Select seems to be getting better efficacy than other precision platforms that we have. But we suspect that one of the reasons is things like this anatomical design that's very natural and probably feels very comfortable at the tongue might help to not lower the arousal threshold for that patient, or maybe that natural surface helps keep a certain amount of muscle tone in the pharyngeal muscles. We don't know. Those are just wild, swags, wild ass guesses, whatever you want to call it. But they're guesses hypothesizing, why do those particular device designs seem to have higher efficacy? But maybe because we're not only lingualists, not only smaller, not only comfortable, but maybe a little bit more natural feeling to the tongue and the mouth environment, that the patient doesn't view it as something foreign. When you have a smooth surface, like most of the devices have, even our IA, that's not a natural feeling. We're more commonly, we're going to feel those indentations between the teeth. So it's really about the material selection, the way we make the devices. It's so much more than just, what kind of CAD CAM, because I could show you slides of other CAD CAM devices that are made, printed nylons that are bulkier than our oral appliances, or have been opened up 7 or 8. I actually had one made for myself that has this vertical blocking mechanism on the occlusal that was open 10 millimeters more than my Evo. That's right. I stacked the two devices with a model in them, and I measure the height, and the difference in the height was 10 millimeters. That's phenomenal. And that's not what I prescribed. I prescribed a device in this position, and I got a device that was that position plus 10. Or if we get a device back that has so much bulk or material that it's just hard to keep clean or hard to get the tongue space in, it just doesn't make any sense. You're probably comfortable with Sutherland and Sestuli's graph. It's a great concept here of looking at CPAP has great efficacy, but poor compliance. Oral appliance therapy has great compliance and not as good of an efficacy. And there's this whole discussion around what's called mean disease alleviation, the product of efficacy times adherence, making the math super simple. If CPAP had 100% efficacy and 50% compliance, it'd have 50% effectiveness, 50 times 100. If oral appliances had 70% efficacy and 90% compliance or adherence, 90% times 60% would be 54%. So you could, or times 70 would be 63%. You could have significantly higher effectiveness or mean disease alleviation than the contrary appliances of something like a CPAP, even though the CPAP itself has much higher actual efficacy. And that's another arena that physicians have to, that we hope to educate physicians on so that they'll embrace this idea of it's not just about the efficacy, it's about how effective the therapy is at reducing outcomes. Well, what does this look like when we look at ProSomnus therapy? Well, if I look at CPAP in the pink, I look at legacy oral appliance therapies in that one shade of blue, I look at neurostem therapy, and I look at the effectiveness of 48% because their adherence is 71. We talked about these numbers earlier, 68% efficacy, crazy. That's the STAR trial and their follow-up STAR trial. It's nuts. And then we look at ProSomnus oral appliance therapy, and we got 90% adherence and 68% efficacy. It's actually a little higher now. We're at 69 overall from all the data points we have. I'll show you that in a minute. And then you look at something like maxillary mandibular advancement surgery, which has really high effectiveness, really high adherence, and really high efficacy. This is the profile we should be thinking about when we're thinking about the different treatment modalities. We could put positional therapy on there. We could put weight loss on there. We could put sleep hygiene on there. There's lots of other things we could do. But the idea is, what's the treatment for this patient that they'll be adherent to, that has a manageable dose with minimal, mitigatable, manageable side effects, that will be effective and reduce their outcomes, improve our outcomes, or reduce their disease state. See, that's really the equation. There are times when we have to look a patient in the eye whose BMI is very, very high, whose AHI is very high, their time under 90 is very high, their nators are very low. They're really not a very good oral appliance candidate. They're going to be very challenged to be treated with oral appliance therapy. Could we treat them? Could we try to treat them if they failed CPAP or they wouldn't wear CPAP? Of course we could, but that shouldn't be our first line of treatment. We should be very supportive of CPAP for that patient. Mild and moderate is a different story. When we get to mild and moderate patients, we've got really efficacious treatment today because the dose management, the precision that we have in these devices, and that's changing the game. ProSomnus is dedicated not to just improving what our patients experience or what we experience in terms of the delivery, the adjustments, fewer repairs, everything like that. It's about connecting that idea to the physicians because they control so much of this $5 billion OSA treatment space. So here's a poster I did last year at the AADSM on dose. And without boring with all the details, because you can look this up online, I can send you this if you want. We started patients at an average of about 50.3 millimeters. 50.3, because some of them we started a little ahead of that, some of them we started a little behind that, more of them a little ahead of that than behind that. Why did we just start everybody at 50%? Because that's where I start asking the question, is that comfortable? And can you make a snoring sound? I call it a poor man's CBCT scan, or a poor man's pharyngometer, or a poor man's MRI. It's my way of assessing, am I mechanically opening the airway when they advance their mandible to that position? Do we have any data that shows pharyngometry or snore test or MRI is predictive? No, we don't. We'd love to have that. That'd be great. Matrix Plus is the only predictive, and they're not around anymore. John Rivers works for us now, fortunately, but they're not around as a company anymore. So 50.3 was the starting place. Okay, 38% of those patients resolved right there. The rest, on average, advanced 1.29 millimeters. I'm not saying we didn't have some that advanced 4. We did. I'm not saying we didn't have a couple that we had to take back because they had muscle soreness. I think there was one or two in this 55 case series, consecutive series that we did prospectively. But listen to that. We started at about 50% of the range of motion. That's less than most other device manufacturers recommend you start at. And we advanced 1.29 millimeters. That's less than most other devices end up having as a advancement mechanism. And 38% of the patients, a little over a third, responded at the initial starting position. And we had 74% efficacy across mild, moderate, and severes, a mix of all three in this group. So the summary of that statement is these precision platforms required lower dose, had fewer side effects. Nobody discontinued treatment. Was there anybody with sore muscles? Yes. Was there anybody we had to move them back and then come forward slowly again? Yes. I think there was one. Was there anybody that had an irritation or anything? Yes, but nothing that we couldn't overcome, nothing that caused cessation of treatment. So this is a pretty neat assessment of the dose and the relationship of dose in oral appliance therapy. The final slide I want to share with you in my part of the lecture today is going back to this original study that I showed you, this dose resulting in better efficacy. And the answer to the question, how high is the entitlement? How good can we get? We don't know. Rimmers and I, Lynn Liptak and I, Eddie Saul, Jordan Stern, some of the physicians we work with quite a bit, Lee Serkin, all good, really good people. I spoke for the American Academy of Cardiovascular Sleep Medicine recently. All really good people who all believe in oral appliance therapy. We don't know how good this can get. When we see things in that JCSM article that say 81% overall efficacy, 94% in the milds and moderates, we're probably getting closer to what the entitlement could be. So maybe it's 95 or 97% of mild moderates. Maybe it's 84 or 85% of the total group of mild, moderate, and severes. We don't know. But whatever that entitlement is, we know that with better device design, better treatment protocols, better materials, lower dose, fewer side effects, better adherence, more precision, we get closer to reaching this level where we're not just comparable to the effectiveness of CPAP, but we might even end up being superior to CPAP. And can you imagine that needle flipping? Can you imagine if we became like some of the Scandinavian countries where oral appliance therapy was a first-line treatment, where 30, 40, 50%, 30, 40, 50% of the prescriptions for OSA patients were written for oral appliance therapy first. They didn't get a CPAP until they failed. We're doing a study with Olivier van der Beek and Mark Bram out of Belgium at the University of Antwerp right now with Prosomnus. They're starting 200 patients on CPAP and 200 patients on oral appliance therapy on Evo with compliance chips. And they're going to go 3 months and then we're crossing them over. And then they'll go 3 months. And we're going to look at the data and see which treatment was more effective, adherence times efficacy. And then we're going to ask the patients, which would you prefer to keep? And we think we're going to make a very strong case. That in our severe indication trial with the FDA, with the current developments that are coming from monitoring systems, we've got a pretty strong story that we can tell to physicians that I think is going to change the landscape of dental sleep medicine forever. You've got my email here. We'll take a few more questions. Michael, you've got a couple of slides too. You want me to go into those now, or you want to answer some questions first? What do you think is the?
Yeah, so we actually got time, which is.
A blessing.
unnatural for you, man. I got to be honest. You always have so much to give. The question is, how much can we fit into the time? So I'll say one thing real quick on your CPAP shift to oral appliance, Scandinavian countries.
Yep.
I've been in the sleep medicine space for a little bit, almost 2 decades. And I started off as a sleep tech. And I got to tell you, by and large, the entire sleep medicine community, physicians, techs, owners of labs, no one 15 years ago thought that home sleep tests would ever overtake an in-lab test. It's inferior. It doesn't matter. These tests are like flipping a coin. And I got to tell you, it was the medical improvement. Medicare approved it for billing, and the technology improvement that won over the community. And then the insurance changed their guidelines. You have to do a home test before you get an in-lab test, unless it's neurologic as a sleep test requirement. So
Crazy.
This movie has played before. We're just in the middle of the oral appliance movie today. And the question
great
is,
analogy. I appreciate that analogy. That's a great story because, and forgetting about the COVID shift, because the COVID shift certainly drove a little bit more to home sleep testing, but even prior to COVID, it was about 60, 65, 35.
Yeah.
And if you go back just a handful of years, it was 90, 10 the other way.
Yeah. Yeah.
Maybe 95, 5. Yeah.
Yeah. Yeah. Nobody wants to be on the tail end of the wave. If we're throwing analogies out, I'm in California. The tail end of the wave is where all the sand gets kicked up. You don't want to be in that end of the wave.
Amen.
You want to be on the front.
I see some good questions up here. Let's tackle some of these.
Yeah, we got a bunch of them. And I'm going to do my best to make sure we hit them all and summarize them.
Let's do it.
One of them, Mark, for Evo, specifically to Evo, because you mentioned it by name. Dr. Boer asked, doesn't the Evo advance in 1 millimeter protrusive increments? And my tangential question is, can it be less than 1 millimeter? How does that work?
Yes and yes. So the default design is a 1 millimeter increment. When you order the device, you're always going to get it in 1 millimeter increments, 5 millimeters forward. You can always go backwards if you want. Unlimited arches, you can go as far forward as you want. I actually have had one patient go 8 millimeters forward because they had to start very retrusively. That's a different story. I've had to take a couple patients back. One patient, my daughter's mother-in-law, I took back 4 millimeters. So it's really versatile that way.
Okay.
So we know that from the studies that the vast majority of patients, not everyone, can tolerate 1 millimeter increments. So that's why the design was set that way. Could you order a 0.5 millimeter? Absolutely. So if you ordered your normal Evo design and you found that, they were good at 2, but when you try to go to 3, they felt uncomfortable, order a 2.5 all day long. Knock yourself out. Honestly, though, if you said, I need asymmetrical advancement because their protrusive path is crooked as hell, then Evo is a very difficult device to use for that.
Right.
I would use a CALP because I can turn one screw more than I can turn the other.
Yep. Great point.
Or I would ask for 5 millimeters of lateral play between the posts instead of 3 millimeters of lateral play. You can prescribe how much you want. And that would allow that patient to have a little bit more crooked path going forward. Also good for a bruxer. So yes and yes.
Okay. So Dr. Boer's on the hunt for you, like the Red October here. So how do you get to a 1.2 millimeter advancement? If we're talking,
you order a CALP, and 1 millimeter advancement would be 10 quarter turns, would be 1 millimeter, and you just do your math from there.
Cool. Awesome. Okay, so a couple of questions summarizing them. What did you mean by legacy appliances in the prior slide? What is defined as a legacy appliance?
Yeah.
And on the chart, is it just Evo that was on the efficacy adherence chart, or was that any other devices?
No, that's when we're looking at that chart, it's all of the Prosomnus precision platforms. I'll be honest, in the vast majority of those studies, it's IA Select, and now Evo. There's almost 700, an N of 700 in the group of studies in that particular slide. Let me go back to that. I just want to show you that. So this has 645. We've got another one I could add to that bubble. If I pulled Evo out, it would be over here, right around 80%, but it would be very small because we'd have about 105. So it'd be over this location over here on the left. And then this would drop from 69% to probably 68 or 67%. So this is oh my God, I can show you the database, but it's this incredible number of 42 different AADSM papers, plus now not 5, actually it's probably 9 ProSomnus papers and studies. We haven't added in this last JCSM study because that just came out. So that'll bump that number up a little bit further. But in that bubble there are all ProSomnus platforms, mostly IA selected Evo though.
Okay.
There's a few herps in there, a few CALPs, but not very many.
Cool.
And then what was the other part of that question?
Legacy
The
appliances.
legacy devices, any other device that's made that is not precision. So let's say there were the first generation of devices where tongue sucker devices, non-adjustable devices, maybe we would classify them as temporary, custom, and precision, or we could say that they were non-adjustable, adjustable, and precision. There's many different ways, but anything that's not a precision device,
yep,
we would call a legacy or predicate device. And unfortunately, even if we see, and I don't want to kick on, there are some other devices that are printed or milled. But if you look at those, and again, I don't want to show you 100 slides, and you and I were already teasing about how many slides I have tonight, but I made it. I got through the slides.
Yep.
So there are some devices that are milled by other companies, and the platform's milled, but if you look at their platform and our platform, made for the same mouth, and that's how I make my analyses and my measurements, my comparisons, ours is 33% smaller. Why is that? There should be no reason. They are milling out of the same kind of PMMA we are. They could mill it just as small as we do, but they don't. We don't know why. And then when they put their parts and pieces on for a dorsal, they put them on by hand. And one side might be bigger than the other and smaller, and so you could get asymmetrical advancement. So I'm not saying that you always do that, but I don't know why somebody would step into the CAD/CAM realm and not use precision and CAD/CAM. That's why we started to make the distinction between CAD/CAM does not mean precision. CAD/CAM just means it was milled.
Got it. Cool. We do have a couple of slides. Let's hit those real fast. And we've got a lot more questions.
There was one question I wanted to answer about the primary difference between Evo and Avant and other studies comparing various new appliances. We do have studies comparing lots of appliances. Avant is a lot bulkier and larger. It's thicker because of the liner that it has. They could have milled it and kept it small and precision, but they put the soft liner in it. Super comfortable. That B-Flex stuff is super comfortable. I love the feel of it, but it does invite more tooth movement, and it gunks up a little bit faster. It can delaminate, etc. And then the other difference is we've only seen one study with any efficacy data on Avant, and that was the poster the year it came out that actually Mark Brum did, and it had 8 cases. 8. Ocho.
Let's hit the slides, buddy. Where I'm trying to keep us on track for time.
All right.
Okay,
Again,
so
code.
yeah, QR code
How do you
here.
get people in the middle of your code? How do you get people in the middle of your code? How do you do that?
We have special marketing people. I don't know how to do that,
Cool,
man.
bro.
You're asking the wrong guy. Guys, if you're on here, we've he's gonna schedule a consult with a sleep coach.
It's cool.
If you're on here and you have any questions about the topic here, but I mean, let's be honest, we're geeking out over this stuff together. We're going way deep in the weeds. And I hope that everybody on here is very aware that this is amazing content that should inform your decision-making. And at the same time, you don't get to do any decision-making unless you're actually treating patients. So we got to treat more folks, unblock the hurdles from our team, that kind of stuff. So if there's workflow questions or anything like that, our team of sleep coaches is happy to help out with that. That's complimentary. Anybody that wants to scan it like Mark did can do that. Mark, you want to go to the next slide?
I do.
If you are looking to light a fire with your team, we'll help you light the fire. If you already lit the fire and you're looking for some workflow smoothing and support for your team, you got some new team members, post-COVID, all that kind of stuff, whatever. This is one of the best places that we could recommend that you go. Not because it's our course, but frankly, we've all been on long virtual courses. This is only an hour, but if you like this, you're gonna love that. Because nobody talks longer than an hour. We do breakout rooms. We're moving. The entire function and purpose of this course is that you exit doing more of you, treating more patients, all of that kind of stuff. So if you're interested in that, if your team's struggling and you want to get them on here, This is one ticket, gets 5 people on, and everybody gets 14 CEs. So it's incredibly inexpensive. I've been told not to say the word cheap. I mean, let's be real. It's the most inexpensive cheap CE you're going to get, and you're going to have some stinking fun. So there's lots of sleep courses out there. We do one of them. If you want to hang out and learn how to do more sleep, we'd love to teach you. Last one here, Mark, if you want to go to that. Both of those codes again, take a picture like he did on his phone. It'll take you straight to the website. We do have a lot of questions, but I'm going to ask one of mine before we get to the other ones. Dr. Murphy.
Yes.
This is not a tee up for our stuff. I'm being serious. If you had to say, what is the thing that would get you to the next step? If you were starting out or you were in the spot where a lot of these guys are, GP practices, dealing with screening, maybe dealing with physicians, what's the order of priority, or what would be the things that you would say, let's pull this out, pull the hurdle out and get the team rolling? What does that look like for you?
You know, you really need somehow to create an experience where the whole team gets on the same page. And I think the biggest problem is we go to a class, we get all fired up and we come back, and then we're bumping heads with our team and our staff because they've got other priorities and other things going on, and things that were very important to us 2 and 3 and 5 weeks ago. So getting all of us on the same page. And so when I see your courses, and I've had a chance to lecture in several of them, they're usually a bunch of people sitting around in a room where there's teams there, not just the dentist, and they're all experiencing at the same time all the kind of learning and growth, so that doesn't mean it's going to work, but there's a higher likelihood it will work when they get back to their office because they all heard the same thing.
Yeah.
And I think that is the biggest hurdle for a general dentist in a general practice. We can learn how to do the sleep part. You can teach that. Greg and Mona do a great job of that, but it's all about this. How do we implement? How do we take it back? How do we get our team all rowing in the same direction? And that's really a leadership question. And so what you become is almost a leadership assistant to them.
Yeah. Thank you. That's
true.
awesome, man. It's just true. And we know it. We sometimes fight it, but we know it. We all do. So I'm gonna try really hard to keep us on track. One, guys, I want to announce the links for the course, the coaching session, and the CE link that I promised earlier. They are now in the chat. So if you guys just wanted the CE, you didn't want to look at either one of our faces and you're out, no problem. There's your link. If you want to hang out, we're going to answer every question that you've asked tonight. 2 people asked while we were talking about the courses, are there any other dates than April? And Tal, Dr. Tal, what's up, man? Your daughter's getting married that weekend. Congratulations. Yes, we do in fact have other dates. We have one of these courses monthly. This discount right now from the webinar is just on April, but frankly, go book the course. I'll give you $200 back personally. It's not a problem. We'll get you taken care of. Click or scan the link, and it'll take you to our events page where we've got all the courses listed. Okay, that knocked 2 of them out. Here's a good one for you, man. For potential TMD patients, is it okay to ask for an anterior discluder or anterior disclusion to be added to EVO or the rest of the line? What are your thoughts on that?
It is. I had a great call with a doctor this morning, actually. We were talking about that. So yes, you could do that. But I guess what I wouldn't want to put an anterior discluder on every patient that had TMD or bruxism or something like that, because now I'd be putting this anterior discluder on a lot of devices. 19 out of 20, 29 out of 30 patients that have those kinds of bruxism or maybe some occlusal muscle disorders, when you treat them for their airway, they get better. And those problems seem to go away as soon as you're treating their airway. So you probably don't need the discluder, but if you felt better having one, put a 2 millimeter discluder on so you can grind it off if you want to later. But I have seen some early studies with some very promising data that internal derangement TMD patients do better with an anterior discluder. And that's interesting. So it's perfectly fine to put those on there. You can have a 2 millimeter, you can have a 4 millimeter, you can prescribe whatever you want. That's the neat thing about, CAD/CAM and precision engineering.
Yep. Thank you, man. That was all you.
Yeah.
I will only add from the sleep tech standpoint, bruxism is a natural sympathetic response to stress on the body. You have no idea if it's oxidative stress, psychosomatic stress. They're just responding.
Well
So
stated.
fixing the oxidative stress is probably an important place to start. Just saying. So how do we get a video of the webinar? That will be emailed to you.
$99.95. $99.95.
Okay, so separate one, Mark, this is for you. And I'm going to say, we had too many questions for this. So I'm going to sum up like 5.
Okay.
Can you please send us the articles, the stuff that you were talking about, and we will actually put it, this will be the most robust webinar recording page that we have to date with those links. So they can get that from you guys.
I'll put all the posters in that JCSM article, stuff like that.
Cool.
All good.
Awesome. Carmen, you asked what at-home tests do you recommend? Mark, you all right if I take that one?
I was just going to suggest that you do, please. Because
Okay.
you happen to have an expertise in this arena that I don't.
It's very narrow. You know,
I'm going to use whatever one you suggest. How's that?
Yeah, thank you, man. So Carmen, the candid answer is you're going to want a unit that is going to do the job. It's FDA cleared. It's a tank because you don't want people to break it. Ferraris are expensive when you break them. You don't want a Ferrari of a home sleep test frequently, and you want a low per test cost. There are several units out there that meet that criteria. We do retail some of those. If you'd like just a blanket answer on that, I'd recommend that you talk to a sleep coach. We can reach out to you for that to help you make that decision. Whether we sell it or not, we're going to give you a candid answer as a coach.
Well
cool.
Stated. I like the idea of a tank and a low per test cost. That eliminated a few of these selections, that's for sure.
Hey, Ferraris are nice to drive, man. I've not driven one, I've been told, but there's a lot of reasons why most people don't own them.
I drove a Viper once. I drove a Viper once.
Ooh.
And a i8 BMW. A friend of mine had one of those. That's kind of cool.
I'm going to hit a couple here, man. Okay, so when you talk to patients about the 90-degree angle, you talked a lot about that tonight.
I don't talk to patients about that.
You don't even bring it up.
Never. They don't know anything about that.
Okay.
That's a doctor nerdy kind of thing that we like to do.
I told everybody we're in the weeds tonight.
Oh, yeah. We're in Nerdville. I'm in my happy place. That's for sure.
You're in your zone. Okay. What are the top 3 characteristics of appliances that help to reduce the OAT dose? Top 3, short answer.
Size, 90-degree post,
that was 2.
and
that's kind of it.
Precision starting position, accurate application of the starting position.
Cool.
And probably in that order.
Cool. Do we have a course in French for the team? We could talk subtitles, but I don't know that we have that available to date. If you want to schedule a call with a coach, we'd be happy to chat with you about that. If we can help out, we'd be happy to.
Michael, we have a French salesperson, actually lives in Madrid in our European thing. He could probably sit in on one of these and mouth over it or something. I'm just, suggesting.
Cool. So that was from an anonymous. So if you want to actually send us your email, we'd be happy to get you in contact and do that. Happy to help how we can. Okay, you already addressed heavy bruxers. We talked about minimum therapeutic dose. Appliance leak, this is a big one. A lot of people asked about this, and I actually typed my own question to summarize it. You talked about appliance leak, which is a fantastic term that directly correlates to CPAP leaking. What are the specific items that impact efficacy? You mentioned loop gain. If you could just list them real quick for us.
So let's say 100% of the patients, right? And we're never going to be able to treat 100% of the patients. So some percentage, let's say, I'm making this up, 10% have either high loop gain, low arousal threshold, weak pharyngeal dilator muscles, or mechanically we cannot advance their mandible far enough. They're mechanically disadvantaged. Those four things probably account for almost all of the non-responders.
Got it.
So that's 90%. So that's 10% of the people when I'm making those numbers up just to make the math work.
Sure.
So now there's 90% we should be able to treat, and we go, huh? We're only treating 60 or 70%. Where's the rest of them? Well, it's because we used a shitty device. We took the bite wrong, or the patient's not comfortable for side effects, or whatever it is, right? All the stuff we could mess up. So that's called efficacy leakage. We're leaking efficacy right, left, and down the middle. So there's a bucket, and you put 100 people in it, and 10 of them jump out. The other 90 should be treatable, and then a few of them leak out.
Yeah.
So
that was, everybody, that was bucket with a B, just so we're clear on our CE talk tonight, okay? Yeah. Aaron, you said once you have an HST and discuss it with the patient's results, any tips to maybe help them like an oral appliance better? I'm going to have, we're way past our CE time. I'm going to be super straight with you. My favorite part of our course is my 1 hour that I talk on clinical treatment planning and hit every single bucket of surgery, CPAP, oral appliance, and doing nothing. You need to be there for that, man. Straight up.
When you do that, I love you saying, and one of your treatment options is doing nothing.
Yeah.
And here's what that entails. I love that.
Yeah. So come hang out with us on the course, find a date that works for you. We will honor the discount. I'd strongly recommend that. You won't regret it. And all of our patients know that they can do nothing because they just tell us they'll think about it and then they leave. Just saying. All right, man, we're almost at 6:15. We've answered I think we've summed up every single question. Any billing questions, any workflow questions, any burning questions, schedule a call with Sleep Coach, guys. We're here to hyper serve you, but we had a specific topic tonight. We got a limited amount of Dr. Mark's time. I mean, guys, it's 9:15. This is like bedtime for some of us. No, 9:15 East Coast time. Some of you are still on from the East Coast, so we truly appreciate y'all. We are here to serve you. If we can answer those questions for you, that Sleep Coach consult is free. We're not going to pitch you a bill of goods. We're going to meet you where you're at and see if we can connect or not. Either way, we'll answer your questions. So I strongly recommend that. For everybody that was on tonight, we truly appreciate you. And Dr. Mark, the floor is yours. Closing comments.
I would just like to thank the Academy, and I'm not going to walk up and slap anybody. That's all I can say.
On that note, make
We're
sure
done.
they're going in the bucket. Thank you all.
We
appreciate you. Have a wonderful evening. Thanks for hanging out with us.
It was fun. Thanks,
See
man.
you next time.